The title of this talk is The Evaluation of Torsional Ocular Forces. It will be conducted using a question and answer format. The first question is, which of the following muscles is not involved in ocular torsional actions? A. Superior rectus. B. Superior oblique. C. Inferior rectus. D. Inferior oblique. E. Lateral rectus. The eyeball has three axes. Routinely, we evaluate the y-axis by asking the patient to look up and down with the eye in various horizontal positions. The x-axis by asking the patient to look from side to side from different vertical positions, but we do not evaluate the z-axis, which can be easily evaluated by asking the patient to look at our index finger while tilting the head to one side and then to the other. This is so because the information gathered by this simple maneuver is difficult to interpret and only clinically relevant in very specific situations. The purpose of this talk is to describe the principles behind the analysis of torsional ocular forces and to mention the situations in which the evaluation of torsional forces are warranted. So let's start with anatomy and physiology of torsional eye movement. When talking about torsional eye movements, we can orient ourselves by thinking of the eyeball as planet Earth. So we find the equator dividing the eyeball into the up and down halves with an upper pole and a lower pole. We also have the prime meridian dividing the globe into the right and the left halves. This is a more cartoonish representation of the eyeball. Let's say the right eyeball. In it, you can see a black line representing the equator, which must always be leveled for proper spatial visual perception. The upper and lower poles, the line formed by the color interface represents the prime meridian, the nasal retina in gray, and the temporal retina in white. This positional arrangement assures the proper visual spatial perception, as you will see in the next few frames. I will start the explanation of the proper visual spatial perception by adding the image of a man standing on the ground straight up. This image will reach the cornea in the same position. Due to the effects of the lens, the image will be represented in the retina upside down and horizontally flipped. The retina then transmits the image to the retinal map in the primary visual cortex with exquisite and fixed retinal to brain and point-to-point precision. So the cortical retinal map will register the upside down horizontally flipped image. The brain will then process the image in the unimodal and multimodal cortices, and the image will be perceived as a man standing upside up and horizontally unflipped. Now let's see what happens if we perform a rotation in the z-axis in the direction of the arrow as I have represented here. This rotation will obviously change the position of the retina as illustrated here by the shift in position of the optic disc. This shift causes the image presented to the cornea to be represented at different retinal points and as such transmitted to the brain. That because of the fixed and exquisite retinal to primary visual cortex retinal map, point-to-point correlation will register a tilted image. This retinal cortical image will then be processed by the secondary and tertiary visual cortices, leading to the perception of an upside up and non-flip tilted image as represented here. Yet normally these changes are not perceived by us when we tilt our head. This is so because the positional changes of the eyeball are promptly corrected by the quick action of the extraocular muscle, the superior rectus, superior oblique, and inferior rectus. As you can see here, reflected by the change in position of the anterior eye segment, and in the retina by the corrected position of the disc. Hence, the information passed on to the primary cortex from the retina will be correct, and as the result, our perception of the position of the man will also be corrected. This quick action is orchestrated by the combined efforts of the vestibular system, the sensory organs of the neck muscles, the brainstem, and the cerebellum. So the answer to this question is E. Next question. When tilting the head to the right, the blank. A. Right eye extorts. B. Left eye intorts. C. Right eye intorts. D. None of the above. I will now incorporate the eyeball cartoon to a figure of a child's head, which I have now moved to the top middle of this frame to give me room to illustrate what happens during right and left head tilt. So when the head tilts to the right, the position of the eye changes in accordance with the new head orientation. Thus the equator is no longer leveled nor the prime meridian straight up. But this new eye position is not there for long because it is corrected by the action of the left eye extortors, the inferior oblique and inferior rectus, and the right eye intort, the superior rectus and superior oblique, as you can see illustrated in this frame. So the answer to this question is C. Next question. When tilting the head to the left, the blank. Right eye intorts. B. Right eye extorts. C. Left eye extorts. D. None of the above. Where we too tilt the head to the left, as illustrated here, the normal position of the eyeball's equator and prime meridian will be altered. Then the right eye will extort by the action of the inferior oblique and inferior rectus, and the left eye will intort by the contraction of the superior rectus and superior oblique. And therefore, the altered position will quickly be corrected. So the answer to this question is B. At this point, I will bring the mnemonic master to tell you two clinical pearls. The first one, the eye on the side of the tilt goes in. Notice the magenta eye in the words tilt, in, and intort. So if you tilt your head to the right eye goes in, intorts, and the left eye goes out, extort. But when you tilt your head to the left eye goes in, intorts, and the right eye goes out, extorts. The second pearl is that muscle inserting on the top of the eye, intort, that is, rotate the upper pole of the eye towards the nose, whereas the muscle inserting on the bottom of the eye, extort, that is, rotate the upper pole of the eye towards the ipsilateral ear. I will now introduce another question. With right intortor's weakness, the diplopia worsen when the head tilts toward the side of the weak muscle. A true, B false. In this frame, I have represented forehead with monovision as indicated by the single man figure. If either of the right intortors, the superior rectus, superior oblique, or both are weak, the right eye will extort and double vision appear. If there is right eye extortor's weakness, the right eye will intort and diplopia will appear. If the left intortors are weak, the left eye will extort and diplopia will appear. And if the left extortors are weak, the left eye will intort and diplopia will appear. So now let's specifically look at what happens in patients with right intortor's weakness when the head is tilted. And let's start by representing the head with the extorted eye in the top middle of the frame. We know from our prior discussion that for monovision to occur during head tilting to the right eye has to intort and the left eye to extort. And when the head is tilted to the left, the right eye must extort and the left eye intort. I have now added to this frame two tables. This table summarizes what normally happens when the head is tilted to the right. When the head is tilted to the right eye intorts by the action of the superior rectus and superior oblique, and the left eye extorts due to the contraction of the inferior oblique and the inferior rectus. The table on the other side lists what happens when tilting of the head is to the left. When the head tilts to the left, the right eye extorts by the action of the muscles inserted in the lower pole, and the left eye intorts by the action of the upper pole inserted muscle. So, when we have a patient with right eye intortor weakness, that is, with right superior rectus weakness or superior oblique weakness, and the patient tilts the head to the right, the left eye, being normal, will reach its normal position with the equator leveled and the prime meridian straight up, whereas the right eye will not, and double vision will worsen. The reason for the worsening of the double vision with right head tilt in patients with right intortor weakness is because the new right eye position brought about by the right head tilt requires the intortors to generate more force to reach the normal position of the eyeball than the intortors had to generate when the right eye was in primary position. And since in this case at least one of the intortors is weak, the force generated by the intortor is not enough to rotate the eye the distance required to achieve the normal position. When tilting the head to the left, double vision will be less because the right eye intorts are not involved in correcting the new right eye position, and to a certain degree because the new position of the right eye brought about by the head tilt to the left fixes the deficit, as illustrated by the leveling of the equator in the right eye. So the answer to this question is A. Next question. With left extortor's weakness, the diplopia worsens when the head tilts away from the side of the weak muscle. A true, B false. When the weak muscle is a left extortor, as indicated here by the red background and illustrated here, right tilt increases diplopia because the left extortors, in order to adjust the left eye to the normal position, now are required to generate more force, and they are not able to do so. With head tilt to the left, diplopia decreases because of the leveling of the equator by the change in the left eye position brought about by the tilt, and the fact that the left extortors are not needed to achieve normal eye position. This is so because when the head tilts to the left eye positional correction is achieved by activation of the intortors. So the answer to this question is A. At this point, I will again bring the mnemonic master to give you two more clinical pearls. The first one, diplopia due to intortors weakness is worse when the tilt of the head occurs in the direction of the weak muscle. This figure summarizes the consequence of intortor weakness. When the right eye is affected, tilting the head to the right increases diplopia. When the left eye is affected, tilting the head to the left makes diplopia worse. The second pearl is diplopia due to extortor weakness is worse when tilting the head in the direction opposite to the weak muscle. To the figure we were just working with, I have added two cartoons indicating the consequence of extortor's weakness. In patients with right extortor weakness, turning the head to the left worsens diplopia. In patients with left extortor weakness, turning the head to the right worsens diplopia. I will now introduce another question. The analysis of torsional ocular functions is the first step performed during the three-step test. A true, B false. The three-step test is performed in the presence of vertical misalignment to determine the affected muscle. It is useful in patients with recently weakness of a single vertically acting muscle. We start with the 4 vertical muscles of each eye. The first step excludes the elevators muscles in the elevated eye and the depressor muscles in the depressed eye. Hence, we are left with 2 possible affected muscles in each eye, either 2 elevators or 2 depressors. The second step is based on excluding the normal muscles in each eye based on the insertion. Thus leave us with one possible weak muscle in each eye, inserting at either the upper pole or at the lower pole of both eyes. When the higher eye in primary position remains so on ipsilateral gaze, the possible weak muscle inserts at the lower pole of each eye. Hence, when the right eye is the higher one in primary position and remains so when gazing to the right, the involved muscle is either the right inferior rectus or the left inferior oblique. And when the left eye is the higher one in primary position and remains so when gazing to the left, the involved muscle is either the right inferior oblique or the left inferior rectus. On the other hand, when there is a shift, the insertion point of the weak muscle is the upper pole. So when the right eye is the higher one in primary position, but when gazing to the left eye is higher, the involved muscle is either the right superior oblique or the left superior rectus. And when the left eye is the higher one in primary position, but when gazing to the right eye is higher, the involved muscles is either the right superior rectus or the left superior oblique. The evaluation of torsional forces is the last step in the three-step test. This step is performed once we are left with two muscles with similar torsional function but with different anatomical angles, one oblique and one rectus in each eye, as occurs after the second step. The three-step test tells us which is the eye involved, hence which muscle is weak, since after the second step only one muscle remains in each eye as possible culprit. The affected eye is selected by choosing the eye on the side of the worst diplopia or more vertical misalignment. Once the affected eye is selected, you need to make sure that the affected eye vertical position goes in tune with the affected muscle. That is, if the superior rectus is the weak muscle, the affected eye should be lower than the normal eye. If the superior oblique is the weak muscle, the affected eye should be higher than the normal eye. So the answer to this question is false. Thank you very much for your attention.